are live, right? Team, we are live now?
No, sir.
Yes, sir, we are live.
We are live now, right?
Yes, sir.
Okay. I mean, you allow participant to join?
Yes, sir, we have allowed, sir.
Okay, okay. Thank you very much. That's what I want. Okay. We need also Dr. Danish. I will try to contact him. Abbas, if you can please ask Dr. Sati because he's the first speaker, please.
Yes, Dr. Muhammad, I asked him already.
Okay.
Yeah, Dr. Sati, I think is there.
Yeah, he's connecting. He's now.
Yes.
Good.
So good evening, Dr. Prasan and Dr. Tariq. Good evening, everyone.
Hello.
Good evening.
Hi Abbas, how are you doing? All good?
All good, boss. All good, Dr. Prasan. Everything is okay.
Hi Dr. Satya, good evening. How are you?
Hello, sir. Good evening. Good evening. I'm good, sir. How are you? Long time.
Long time, yeah. Good. All good.
Yes, sir.
دكتور مجدي معانا اليوم.
He is in Saudi Arabia. He told me he will try to join after praying because now he is, I think, in Mecca. So in Medina, I think according that he will pray and he will try to be with us at the end, maybe inshallah. He will try.
Is Mactil here, Prasan, both types, type 1 and type 2, or?
I'm primarily presenting type 2 because type 1 is very rare. You hardly encounter type 1. I've probably had just 1 or 2 cases, but I can't somehow trace the images. So majority of them are type 2 and they're asymmetric, and that's the more common type actually.
Yeah. Bilateral 1, you mean, isn't it?
Yeah, bilateral, but sometimes it's asymmetric. You know, you'll have one which is more involved than the other, and then the vision is also different in patients. But the thing is, what is most important is a lot of these patients, because they have these cysts within the retina, they get injected with intravitreal. And intravitreal injections have actually no role.
Yeah, exactly. Yeah. Nothing can
These
be
are
done,
atrophic cysts.
unfortunately. Yeah.
Pardon?
Nothing can
Pardon?
be done, unfortunately. Yeah.
Yeah. So if they're seen by certain doctors, you know, some doctors on the OCT, if they feel there's a cyst, they will inject, and then they realize that, you know, 2, 3, 4 injections, nothing happens.
Yeah.
Because these are not cysts because of leakage. They are actually atrophic cysts.
Yeah, exactly. Yeah. Degeneration,
Yeah.
neuroretinal degeneration. Yeah.
Absolutely.
Exactly.
So
The most unfortunate thing.
Pardon?
The most unfortunate thing is most of these patients are also diabetic. So diabetic with the cyst in the macula, it's over. You know, it becomes a good recipe for an intravitreal
Injection. Yeah. True. Very true. So it's more
And
of a
another-
basic talk, you know, mainly to highlight certain
Actually,
points.
sir, I have observed one thing. When we were there way back in India, we used to see the characteristic, you know, the whitish hue around the fovea, which are seen in type 2 IGTs. But unfortunately, I don't see that those whitish hue among patients here. I don't know if maybe it has to do something with the RP or I don't know. I'm not very sure about it. But the characteristic, the hue which you get around the fovea is not too very commonly seen here. I don't know.
You mean the crystalline deposits, isn't it?
Yeah. So not too very oftenly seen here.
I mean, my main bulk of patients are diabetic. I've seen maybe 3 or 4 patients of them only already has been diagnosed, you know.
Yeah. I mean, at least way back in India when I was in urban, you know, it used to be a spotter, you know, just like that. When you just see in a 90D lens, you could see those crystalline deposits with a cyst, and you know, you could just do it. But unfortunately, I mean, you don't see these pattern.
Yeah.
What is it that you see here?
Good evening,
Again?
Dr. Danish.
How are you?
Hi.
Hello, sir. Good evening.
Sorry, I got a little late.
Yeah.
No problem. It's okay. We are still, but just I thought maybe you are mistaking on the time.
I
That's
did.
why
You know
everyone
what?
I'm
I thought
calling.
it was 10:30 your time, and I was waiting till midnight. I'm sitting on my desk waiting for midnight.
No, you know, only in Ramadan we are making different, but now every time it will be 9 o'clock.
Okay,
UAE,
so 9 o'clock
that's
is a good time.
Yeah, good time. That's yeah. At least I know it's still a little bit late for you, but,
No, but
yeah,
it's
something
fine.
better.
But midnight is a little difficult. So I was waiting how I'm going to keep myself awake till midnight.
Oh, it will be,
Coffee.
inshallah. We'll try to move so fast, inshallah.
So I was just asking, how do you diagnose juxtafoveal telangiectasia over here? Like, what is it? What do you see that raises the suspicion?
Yeah, I think, sir, you just joined now. We were discussing how most of the times the patients are having diabetes, and then you do an OCT and you see a cyst. And you know, after probably failed attempts of intravitreal infusion, people diagnose that, you know, the patient is having IJT.
Okay.
So,
You know,
yeah.
some patients don't have the classic whitish look. But if you're doing an indirect and you just look from side to side,
Yes, sir.
while watching, suddenly you see that it's become you're seeing a little grayish appearance on one side. That gives you the clue.
Correct. Yes, sir.
Whereas in the diabetic, what you see, you'll have a microaneurysm and you'll see some whitish area around that. Here you won't see the microaneurysm.
Yeah. Okay.
Oh, you mean type 1, Dr. Talwar, isn't it?
Yeah. So basically, the the microvascular abnormalities very rarely seen with juxtafoveal telangiectasia. Mostly, what you see is the whitish grayish look. And when you do the OCT, you will see in the deep OCTA, you can see the vascular anomalies in the deeper layers. So, and the cysts are characteristic. The underlying RP is intact. That is not affected at all. So you know that you're dealing with this disease. So it's almost pathognomonic.
Sure.
Yeah.
Good.
So, Prasan, you don't need to go now. Already is the
I'll go.
Sorry.
Finish. My discussion is done. Yeah.
Why you don't want to stay for the subsequent part of the session?
Maybe you
I'm
can
just
talk about
joking.
this one, Dr. Danish. Try also to give some cases, then he will leave immediately.
I think we are live now.
Yeah, we are already 9 and 2 minutes, but we can wait again another 3 minutes so we can have more attendees.
Can I quickly check my screen once, the sharing?
Yeah, please. Can you stop share, please, the AV, so that Dr.
can. I will.
Okay.
Yeah. Can you see the screen?
Yes, please. Just make it on a slideshow. Okay, excellent. Yeah, it's moving very nice. Okay.
Okay.
So we can keep it till, all right.
Okay. Stopping this here.
You can stop sharing. Dr. Satya, if you want to share your screen to just to check.
Is it visible, sir?
Yeah.
Yes, yes, yes. Okay, we can stop share. Okay. Another 1 minute and we will start.
Dinesh, sir, how is it in Delhi? Is it really hot?
Really hot, but it rained today. It's
Ah,
still
okay.
raining intermittently. So today it will cool down, but then it goes sizzling back to 44, 45. But you know, just like for you people, temperature goes high, but with air conditioning, you really don't get to know what's happening. So I know I moved from an air-conditioned house to an air-conditioned car to an air-conditioned clinic. I never get to know what's happening. I don't even get to know when it rains.
In South, it seems to be raining incessantly for the past 1 week or so. In fact,
Delhi,
we were fearing.
last 2 days we've had rain. One of my colleagues in Guwahati told me he needs a blanket to sleep at night. Is that so? Wide variations. So how hot is Dubai?
I think it's slowly getting warm. Mornings
not
are
warm
still
yet.
pleasant.
Huh?
Yeah.
Mornings are still pleasant, but I think mid-morning and afternoon becomes really hot.
Yes, I think climate change is finally taking a toll on everybody.
Absolutely.
So,
Yeah.
So maybe if you allow me, we can start now our meeting. Thank you very much for being with us here. Good evening, good morning, good afternoon, and salam alaikum, every friends and colleagues, wherever you are. I would like to welcome you to Al-Som Yom, the weekly meetings that we are conducting every week almost. And we are conducting 3 types of series. We are starting with 2 series, one of them about uveitis and the other one is medical retina. And today is a medical retina series, episode 4. First of all, I would like to introduce our speaker today. Please, if you can share with me the screen, the team, please. Today, we will have in the panelist, Dr. Majdi Musa. He will be a little bit late, but he will try to be with us, inshallah, hopefully. He's a professor of ophthalmology and veterinary retinal consultant, director of medical retina units, chief of digital imaging and laser unit ophthalmology department, faculty of medicine, Tanta University, Egypt. And we are having today also, I am glad to have my dear friends and my neighbors, Dr. Tariq Siddiqui. He is an MB FRCSI ophthalmology, consultant ophthalmologist, medical retina and diabetic retinopathy specialist, Rashid Center for Diabetes and Research, Sheikh Khalifa Medical City, Ajman, UAE. For our speakers, as usual, we are having a 2-part of the meeting. The first part, it will be today presented by Dr. Satya Jakit, and he is an MS DNB FRCS specialist ophthalmologist and veterinary retinal surgeon, Borjil Medical City, Abu Dhabi. And welcome, Dr. Satya. This is the next week we are with us. We are happy that you are with us all the time.
Thank you, sir.
My dearest friends, colleagues, and brothers, Dr. Prasan Rao, he's an FRCS UK, MS Ophthalmology, DIP, NP, FRCPS, DO, DOMS. Most of them, I don't know what the meaning, yeah, but Prasan, it's a very high things, good, important to mention all this. MBBS, he's a medical director, specialist ophthalmologist, and vitreoretinal surgeon, Midcare Eye Center, Dubai, well-known figure in vitreoretinal surgeon in UAE.
Thank you.
Welcome, Dr. Prasan, and thanks for accepting our invitation. I would like also to introduce one of the guest speakers, friends, and a father of ophthalmology, our momentum that we are learning a lot from him. I'm all the times feel happy and comfortable when I'm dealing on doing any sessions when I found Dr. Danish Telwar with us. He's a senior consultant eye specialist and vitreoretinal surgeon, Apollo Andhra Pradesh Hospital, New Delhi, India. Director Vitreoretina and Laser Service Center for Sight, New Delhi, India. Thank you, Dr. Danish, for accepting our invitation. I know you are busy, but we are all the time behind you till we get a chance to be with us. Thanks a lot all the time. So we will start now. Can you share the screen? Just let me see the agenda, please, if you don't mind. Okay, go down, please. So let me, okay. So the first session, it will be, I think, about Bioview, and Dr. Sati will present that one. Then we will go to our main sessions, the four episode of Master Medical Retina from A to Z. And today we are having a very interesting cases about telangiectasia that will be presented by Dr. Prasan. Peripheral vascular disorders that will be presented by Dr. Danish Telwar. Then we will have an applied cases by Dr. Prasan with discussion with the panelists. Also, Dr. Tariq Siddiqui, he will have one case presentation after Dr. Prasan. So let's start, and without any further delay, Dr. Sati, the mic with you. Thank you.
Thank you. Thank you, sir. So, good evening, my dear friends and senior colleagues. Today, I would be discussing on the use of Bioview for diabetic macular edema. Recently, we have had the approval by the MOH as well as by the health authorities for the use of Bioview for diabetic macular edema. So we will be discussing about the significance of the use of Bioview, as well as I would be sharing our experience with the use of Bioview for diabetic macular edema. So to begin with, is the presence of fluid very important in diabetic macular edema? So as we know, one second, please. Yeah. So as we know, in diabetic macular edema, the fluid is a result of disruption of the inner blood retinal barrier, and this can lead to a vision loss. So there is both the presence of intraretinal fluid as well as the subretinal fluid, which may occur relatively later in the course of the formation of diabetic macular edema. And the accumulation of the extracellular fluid and expansion of tissue is one of the major reasons for the decreased retinal sensitivity and the decrease in vision. So as we can see in protocol T, the intraretinal fluid as well as the subretinal fluid were associated with the worsening of the best corrected visual acuity. So we can see that in protocol T, when the baseline, when there is presence of intraretinal fluid as well as subretinal fluid, there is usually the vision which is on the worse side. So the significant proportion of eyes with diabetic macular edema have persistence of the fluid despite the repeated anti-VEGF therapy. And this can be seen that close to about 81% of the patients on month 12, close to about 56% of the patients on month 24, and 40% in about 3 years still had the presence of fluid despite repeated anti-VEGF therapy. Also, it can be seen that in protocol T, the significant proportion of eyes with diabetic macular edema have persistent fluid despite anti-VEGF therapy. So it can be seen that up to 37% of the patients in the aflibercept arm and about 46% in the ranibizumab arm had the presence of fluid despite the use of antivegf. And these are the patients which needed rescue lasers between 24 weeks to 48 weeks. So what does this say? The patients with residual fluid gained fewer letters in the long run. So it can be seen that when there is a presence of fluid, the chances of the patient developing good amount of vision starts coming down. So certainly it is a pointer for the fact that, you know, drying of the fluid is one of the major aims which we have to aspire for. So when we come to the robust vision gains with the Bioview, this has been associated with two studies, the Kestrel study as well as the Kite study, which was a phase 3 study in different countries with the use of brolucizumab in the use of diabetic macular edema. And what were the primary objective was to demonstrate the non-inferiority of Bioview versus Ilia, that is the aflibercept. That was the primary objective, with the primary endpoint being the change in the baseline visual acuity at the end of 1 year. The secondary objective was to determine whether the proportion of patients maintained on the 12-weekly dosage of brolucizumab, and to determine the proportion of patients with the presence of intraretinal fluid and subretinal fluid. Also, the proportion of patients which achieved a central retinal thickness of less than 280 microns was also determined, and the probability of remaining on the 12-week regime was also looked into. So when they were comparing between the Bioview or the brolucizumab with aflibercept, in both the studies, the patients were matched in all the respect as per the study design. And it was seen that in the Bioview arm, the patients were chosen to have a 6-weekly injection of Bioview, and this went up to 5 injections. Whereas in the aflibercept arm, the patients were given 5 injections at the interval of 4 weeks each. So what was seen is at the week 24, both the group of patients, they received the injections. And at the week of 32, an assessment, a preliminary assessment was done using blinded observers. And based on the presence of intraretinal fluid as well as the visual acuity, they were either chosen to continue with 12-weekly dosage of Bioview or 8-weekly dosage of Bioview. And whereas in the arm of Ilia, the patients were observed or they were continued with a 8-weekly injection. So what is that which was seen? From the loading dose to the maintenance, it has been seen that Bioview was evaluated to have a minimum number of injections frequency. And this went up to the 52 weeks period. And also the maintenance was maintained at the dosage close to about the patients were maintained up to 52 weeks with the 12-weekly dosage. I don't know, this one doesn't seem to be moving. Yeah. One second. Yeah. So then moving further from the 52 weeks to the second year, again, it has been seen that the patients in the Bioview arm were maintaining at the 12-weekly dosage itself as against the aflibercept arm. So essentially, the patients treated with Bioview experienced comparable vision gains as that of Ilia or aflibercept, but with a reduced injection frequency. And we can see that in both the study groups, the number of injections was far less in the Bioview arm compared to the Ilia arm. Also, it has been seen that more than half of the patients on Bioview were maintained on the 12-weekly dosage up to 52 weeks. And also, it has been seen that close to about 88 patients maintained with the 12-weekly regime even beyond 52 weeks in both the studies. A lower proportion of patients treated with Bioview had intraretinal fluid and the subretinal fluid at 32 weeks, which has been demonstrated here, as well as in the 52 weeks too. It has been seen that the number of patients treated with Bioview had the lesser percentage of intraretinal fluid and the subretinal fluid. A higher proportion of patients treated with Bioview achieved absence of the diabetic macular edema. That is, the central subfield thickness was less than 280 microns, both in the 32-week group as well as in the at 52 weeks. So coming to the safety profile, yes, there was a concern about the safety of Bioview, but it has been seen that in both the studies, that is the Kursville study as well as in the Kite study, it was almost comparable with most of the ocular and non-ocular side effects, but it is only one aspect of it which was a matter of concern, that is the presence of retinal vasculitis as well as vascular occlusions. But other than that, it was almost comparable in both the groups. So in short, the dosage of the recommended dosage of Bioview is 5 injections at 6 weeks apart as a loading dose, and the maintenance can be varied between 8 weeks to 12 weeks based on the response after the loading dose. So with this, I just thought of sharing our experience. Very recently, Bioview was approved for the use in diabetic macular edema. So I have a few cases, and I just thought that I could share our experience. My first patient was a 34-year-old male, and he was a diabetic since 8 years, and his vision was 660 and 624, and the anterior segment were normal, and the intraocular pressure was also within acceptable limits. So in the right eye, the patient was having a diabetic macular edema of close to about 455 microns. Even the left eye also had a macular edema. This patient had undergone previous laser treatment, and after 1 month of the use of Bioview, it can be seen that the macular edema has been reduced to 253 microns in the right eye. So the second patient again is a 52-year-old male with 13 years of diabetes, and the vision being 624 and 618, and the intraocular pressure again was within normal limits, and the patient was having a right eye diabetic macular edema of about 309 microns, and the left eye was about 246 microns. And 1 month post injection, again it has been seen that there was a marked reduction of the diabetic macular edema in the right eye. The third patient is a 62-year-old male with 17 years of diabetes. The right eye was having a vision of 660 and the left eye too. The intraocular pressure was again within normal limits, and he had a large cystoid kind of a macular edema with close to about 693 microns in the right and 455 in the left. And 1 month post injection, it can be seen that the macular edema reduced drastically to 398 microns. And the fourth case being again a 64-year-old male with 22 years of diabetes, vision with 636 and 612, and the IOP again within acceptable limits. He had a macular edema of close to 332 microns in the right eye, and with a 256 microns in the left. And post injection 1 month, it has reduced significantly to 259 microns. So these were a few of our cases in which we have had a remarkable reduction in the macular edema. I just thought of sharing our initial experience with Bioview. If there are any questions, I'm ready to take.
Thank you very much, Dr. Sathya, for this excellent presentation.
Thank you, sir. Thank you.
There is one question came to my mind while you are presenting the Bioview in management of diabetic macular edema. Is just now, I think, get approval in UAE to use as a management of all the cases that you share. Are there before under treatment, or they are naive? I mean, you are shifting from another anti-VEGF because we didn't found that you mentioned this point.
Yes, sir. So all my cases have been treated earlier with either an anti-VEGF or with a dexamethasone implant. So none of my patients are treatment-naive patients. Yes, in the last 1 month, I have injected several patients initially who have never been taken any other kind of a treatment. But I didn't have the post-op or the post-injection photographs as well as the OCT, and they're not even 1 month old. So I just felt that, it wouldn't be appropriate for me to share those patients.
Well, what I mean, Dr. Satya, this is just switching from another modalities of treatment to a new method.
Absolutely, sir. Absolutely, absolutely.
Okay.
Yes.
Regarding the visual acuity, because we didn't also notice if you tell us if there is any improvement in the visual acuity. I know there is a drying of the macula, but that looks very nice. Is that associated also with any improvement in the vision? Yes,
sir. Yes, it is. But as you can see in most of these patients, they still had a residual macular edema. It's not that it was completely dry and that was the end of the treatment. So certainly it is not that, it is a fairy tale wherein which they were having 100% vision. That's not what I'm trying to say. It's a long way to go. It is not with one injection that, we are going to conclude the treatment. Certainly there is an improvement in vision, but, we need a longer follow-up in order to really look into these patients.
Sorry, go ahead.
Yes, Dr. Yes, Dr. Tariq.
Yeah, can I ask a question, Satya? I mean, about the main concern, I think, in these studies and practical as well, is the induction of, they can induce retinal vasculitis. Do you know the rate of vasculitis after Bioview injection? And what type of vasculitis? Is it severe, and how do you treat it? I mean, do you have the instance?
No, honestly speaking, I don't have an experience. I don't have a personal experience of having a retinal vasculitis.
Yeah.
No, in fact, I must have, with my experience, to close to about 100 patients at least. Touch wood, I have not had an encounter with such a kind of a situation.
Yeah, the results of Kestrel and Kai looks beautiful when you compare it to aflibercept, but our main concern is that it can trigger really retinal vasculitis, So I mean, this is quite a bit of worry about the surgeon.
I think Dr. Siddiqui, if you can go back to what Dr. Satya present in the beginning as the study, and he showed clearly that the percentage is completely different than what we have seen in AMD, and the percentage is completely just, I think, one case in each. And there is even, I have attended several lectures about this one, and it is also mentioned that these cases, they have something related to a previous inflammatory process. So it is a very, very safe in comparison what we are knowing about. It is something new, but it was very, very safe, and it is less than 0.05, I think, or 0.05 percentage of vasculitis. But the other inflammation, it is also comparable with the others. Even this one, it was, I think, in kite, but in Kestrel, but in kite, there was no reported even in vasculitis. You can go back and share that this slide if you want to.
Yeah, can you go back, Satya, please, because you don't mind, because it looks beautiful. I mean, comparably vision-wise, dryness of the macula, comparable to aflibercept.
Directly to that.
So if you can just see the adverse effects, so it is about 0.5%. That's what has been reported, at least in the Kestrel.
Yeah, but still intraocular inflammation is 7% of the patients. Am I right here, or 3.7? 3.7.
No, it is supposed to
go down, please.
Hello.
Here it is. Here it is. You can see here the patient with intraocular inflammatory. You can see here it is. Even there is some 7 cases which is not 7%, is a 3.7%, and it is there even available even in aflibercept in 0.05, and you can find that this is because we have the castrel and kite. Castrel either aflibercept. Here you can see this is what I'm saying. Patient
and the kite it is lesser.
vasculitis. The kites there is no inflammatory either in Bioview or aflibercept. In only in castrel it is one case, and I think they have mentioned something about that case. I don't remember, but Prasan, if you have any, if you remember about that. But it is only one case found in the whole study, which is both either kite or castrel, and only one case. So it is very safe in comparison to what we are used to have. Inflammatory, it is available in all, even you can see here in kite, they are finding 3 cases and 3 cases of Bioview. So almost similar. I mean, it is a matter of, collecting the data and information, and sometimes by chance you can get in one place more than others. But it is not what we used to listen when we are talking about AMD. Prasan and Dr. Danish, please.
Dr.
Hello.
Yeah, Danish, please.
Dr. Amri, you perfectly put it. As you mentioned, in AMD, the incidence of intraocular inflammation is much higher with Bioview. We generally say it's about 4% of intraocular inflammation, 3% with vasculitis, 2% roughly with vein occlusion, and less than 1% of them lose vision by about 15 letters. But that's AMD. So the good thing about Bioview and DME was we knew DME or diabetic retinopathy as an inflammatory pathology. So the results of kite and castrel were totally different. We were anticipating that the incidence of inflammation would be much higher. But if you look at the results of kite and castrel, you can clearly see that the incidence of inflammation is much lower. So there have been various theories which have been put across as to why this happens. And the good thing is that, someone has asked in the Q&A, you have inflammation, so you should stop using Bioview. In fact, we know Bioview is one of the best agents for drying the macula, both in AMD and in DME. And having said that, I think with DME, we are much more confident. The second thing is the injections in AMD are on monthly basis, whereas DME, we give them at 6-week intervals. It's not recommended to be given on monthly basis. That could be also one of the reasons why the incidence is much lesser in DME patients.
I think there is one point we have to also to remember about even in AMD, what we found in real life practice is completely changed than what we have seen in the real study. The practice is changed, and the percentage was going low and less in comparison what we have seen in the real study. The study that done before. This one, okay, Dr. Prasanya.
I have a question to Dr. Satya. Do you do bilateral injections of Bioview in the same session?
No,
or
sir.
Would you want to do it separate?
Never. I have never done any bilateral injections. In fact, I don't really advocate this, at least for Bioview with, when there is a chances of adverse reactions. So certainly it wouldn't be advisable.
What about Ilia? You don't give Ilia or Lucentis? No bilateral.
The only situation where if I have to give bilateral, maybe in ROP, but not otherwise. I never give bilateral injections. I have a question to Dr. Dinesh. Sir, with your experience with the use of Bioview in India, if you could please share, sir. Because I
haven't used Bioview for DME, but yes, there are reports that there are lots of people who have started using it, and it does work. The question I would have to them also and to you again, you said you had shifted from some other drug to brolucizumab. So what was the degree of, were these recalcitrant patients or patients who had some degree of edema which used to resolve and come back and recurrences were more? There's a difference between recurrences and recalcitrants. So which category were these?
So all these patients were having persistent diabetic macular edema. They were my old patients and who are quite stubborn. So I mean, we could label it. And with my experience with the use of Bioview for AMG, honestly, I have to confess that it was more of a curiosity which made me shift to this than having any rationale.
Yeah. So patients in whom there had been no change in edema for say the last 3 months with injections of one of the other anti-VEGF drugs, you found that the change was more with brolucizumab. That's
Yes, sir.
you
Yeah,
didn't
that's
give
what
that
I'm trying.
background actually. That's why I'm asking you this.
No. Yeah, I mean, what you have framed it well. It is seen that, you know, with the use of brolucizumab, it is having a better response than having a monthly injection of maybe one of the other anti-VEGFs.
So if you can say that actually Bioview, if you place Bioview in the armamentarium of anti-VEGF, it probably comes before the use of vsozodex. So if the eyes are sort of recalcitrant to anti-VEGF, you can probably try Bioview before you're giving dexamethasone implant, because in the past we didn't have this option. So all the patients were recalcitrant.
If you find that the drug is so good, why wouldn't you want to give it as first-line treatment, especially when you say it doesn't cause inflammation?
Yes. So I think initially what happens is we generally tend to use, that's been my practice. You know, initially you would want to use it for patients who are recalcitrant, in the sense they require very frequent injections or they're not responsive to anti-VEGF. You start using it for those patients. And then with the confidence which you gain in these patients, eventually you want to start treating 9 patients as well. So I think these are clinical trials. So we just need to take points from the clinical trials, but I think we need to build our own clinical experience, which takes time, you know. So I think that's how I do it. I would treat recalcitrant patients first before embarking on dexamethasone implant.
Would you
then once they have a good response.
Yeah. So this is what I wanted to ask you. Would you consider that maybe after 3 intravitreal injections of aflibercept, if you do not get a response, which will happen in 50% of patients, these patients should be considered for brolucizumab instead of vsozodex?
Yes, I would want to start brolucizumab for them, because you want to avoid the sort of the query side effects of dexamethasone implant, because what I've said and done, it's a steroid. So there's no harm in trying an anti-VEGF, and if the anti-VEGF works, you have reduction in the macular edema. I'm not so concerned about the vision, because it depends, you know, how the patients present. If they have delayed presentation, then the visual improvement may not be very significant. So if they had recalcitrant edema for a long time, I think no harm in trying Bioview before giving dexamethasone implant.
I think, Dr. Danish, I get to know that from your questions is not a direct questions. You want to get the information from Dr. Prasan. So I think now we are all the time thinking we can switch between anti-VEGF or not. Most of the time we are, no one is more believers on switch between anti-VEGF. And this is also an new anti-VEGF. So are we going to shift from anti-VEGF to another anti-VEGF, or we go directly to steroid, whatever, Dexa or Uluvian? Actually, today we are having a very big debate about these points, because we are having like a standalone in Georgia about Uluvian, and we are discussing about switching and so on, and we get to about this point you are asking. But this is a new drugs. Before talking, we are having only Uluvian and ranibizumab, and that's the only available. And after a long period of experience, we got to know is there is no benefit maybe to switch between anti-VEGF, and we can go directly to a steroid. Even though some of the our colleagues, they are still believe and they are shifting from one to another one. Also, we get to know now we cannot go more than 3. Most of the time, you don't wait until the chronicity is increased and you have increased diabetic macular edema, and then you shift to a steroid, which can give you maybe a drying, but you are not improving individual acuity because of the chronicity and ischemic changes. But I think these new molecules, and according to everyone, you cannot go directly. You have to build up your experience for a little period of time using this anti-VEGF as switching between anti-VEGF. After that, maybe we can start to give it as a naive patient, especially now we are, we get, that's the inflammation and the IOI is less than what it was anticipated or waiting to see it, and less than what it happened in the AMD. Even though, as I mentioned before, the AMD also in the real life experience, it become changing and not as it was seen in the normal study. I think if that's okay, or anyone want to add any points or to any comment
I
before
would
we
like to
move?
ask you, you talked about Uluvian. Would you prefer Uluvian to vsozodex when you want to make a switch from the anti-VEGF agents?
Yeah.
Would you prefer Uluvian to vsozodex?
This one is another thing that we have to talk about, because there is two approval for Uluvian. If you want to depend on European, then you can go directly from anti-VEGF. In Europe, they are going directly from the anti-VEGF directly to Uluvian. But if you want to follow the American guidelines, and they have to go from Uluvian to a dexamethasone, then you can go as a test, for if there is any steroid responder or not, then you can go to the Uluvian. But this one also is a matter of what are you thinking and the benefit of the patient. Sometimes there is many, point or factors playing your consideration in giving this one or this one. Some people, they are not good compliance, they are not coming, and they are afraid of the multiple injection and so on. But in case of stability, I think it's Uluvian, it's more, because you are going to give injection for 20 or 36 months. And during that period, you can have a top-up maybe after 12 months or 18 months. But if you consider to give it as early as possible, and you are maintaining and you have a good control of diabetic macular edema, control of diabetes mellitus, then you don't need maybe a top-up only maybe after 24, or you don't need it. And most of the time, they are not more than 1 or 2 injections during 36 months. Is there any other further questions or comment, Dr. Tariq?
I think before you decide to go for Uluvian, you need to try vsozodex first, isn't it, to see the steroid response of the patients. I would say you're going to be very brave.
You can use this one, or if you are in Europe, they are not doing this one. You can just depend on the history, or you can give a drops even for the patient and see if he is a steroid responder or not. It is not mandatory to do it, because why? Because the Uluvian, it came earlier than dexamethasone, and the approval to use in Europe for it was before the dexamethasone vsozodex, and that's why they are started immediately, and so they build an experience on that. It's clear, Dr. Tariq?
Yeah.
Okay, so I think it's fair enough for this first part of our sessions, and we have to move now to our speaker. And the first speaker, it will be Dr. Prasan, and he will give a talk about telangiectasia. Please, Dr.
Thank you, sir.
Thank you, Dr. Amri and Niyom, for giving me this opportunity. I'm just going to share my slides. Just a minute.
Sorry to interrupt you, sir.
Yeah.
Your voice is too much low. Can you please speak louder?
Yeah.
Okay, I'll try and speak louder. Is it audible now?
Now it's
Is it audible?
Yeah,
is it audible?
Maybe Prasan, yeah, it is good, but maybe you are decreasing your sound, computer sound.
Okay, just 1 minute. Just 1 second.
Okay.
Is it audible? Better?
Yes.
Okay. Can you see my slides?
Yes, please. Just make yes. Now good.
Yeah. So, good evening, friends. I'll be talking on macular telangiectasia type 2. And just a brief overview about multimodal imaging in diagnosing macular telangiectasia. So this is the overview of the talk. I'll be talking to you about the history, what is macular telangiectasia type 2, the epidemiology, symptoms, the fundus and FA findings, OCT, OCTA findings, fundus autofluorescence, confocal blue reflectance, and finally a little bit of the treatment of macular telangiectasia. Now, in the past, macular telangiectasia had various names. It used to be called idiopathic juxtafoveolar retinal telangiectasia, and this was described by Gass and his co-workers in 1982. Later on, this classification was modified by Gass again in 1993, and he started, they were then called as idiopathic parafoveal retinal telangiectasia, or we also used to call it as PFT. This was in our fellowship days in 1999, and there are basically 3 groups, each of them having 2 subgroups. But this is a very complex classification. So in 2006, Januzzi and his group divided parafoveal telangiectasia in 2 broad main groups. They called it the aneurysmal telangiectasia or idiopathic macular telangiectasia type 1. This is known as MACTEL type 1. And it's also, the second type is known as perifoveal telangiectasia, also known as idiopathic MACTEL type 2. And they divided MACTEL type 2 into non-proliferative stage, which is characterized by telangiectasia and foveal atrophy, and the proliferative stage, as the name suggests, by the presence of subretinal neovascularization. Note, we don't use the term choroidal neovascularization because the source of the neovascularization is the retina in these patients. So what is MACTEL? So for the benefit of all the doctors, general ophthalmologists, the 2 important terms we need to remember is MACTEL is a primary neurodegenerative macular disease and with a secondary vascular involvement. So in the past, we used to think MACTEL was a disease of the retinal vasculature. However, over a period of last few years or a decade or so, we know now it's a degeneration of the Muller cells and the macular pigment. So what is the epidemiology and why am I talking about MACTEL type 2 is because MACTEL type 2 is more commoner of the 2 conditions. MACTEL type 1 is pretty rare. It's usually seen in the 5th and the 6th decade of life. Both males and females have equal predilection and there's no genetic predisposition. However, there are some studies which say there can be a vertical transmission and they're trying to isolate the gene which can be responsible for MACTEL type 2. So the symptoms can be anywhere between asymptomatic, mild blurring vision, positive scotomas, difficulty in reading, and finally, if they have a subretinal neovascularization, they present with metamorphopsia. Now, medical retina for all of us is basically the diagnosis is by pattern recognition. So we look at certain patterns in the retina, and then that's the way we diagnose. We have these ancillary tests which help us to confirm our diagnosis. So in the first stage, you see this slight parafoveal retinal graying. Okay, usually it's on the temporal side. And also sometimes you see this minimal capillary dilatation. If you do an angiogram in these patients, you can classically see these telangiectasia, which is predominantly in the temporal aspect. Same in both these cases. Now, why the temporal aspect? Because if you read the Gass stereo atlas, it clearly mentions that temporal aspect, one of the reasons could be is because it's a watershed zone. And the risk of ischemia is much higher in these patients. Stage 2 is when it progresses from stage 1. You have this temporal or a complete parafoveal retinal graying. This retinal graying is primarily because of loss of translucency of the retina. And this can be complete. So we have a partial graying and a complete graying. And if you look at the angiogram results, in the initial stages, it might be localized to the temporal quadrant, extending superiorly, and eventually it involves the whole of the perifoveal area, which is usually oval, horizontally oval area of hyperfluorescence because of staining. And you always have the central clearing in that. So these are classical images. If you see anything like this in your clinical practice, you can confirm that this is MACTEL type 2. Stage 3 is when you get parafoveal retinal right angle vessels. Now I'm using the term vessels here because in the past, these were thought to be venules. However, there's a recent study in Bioview which said that even arteries can actually be involved in right angle format. So how do you differentiate, how you find out these right angle venules? Because they have this abrupt ending. Normally, if you look at the perifoveal vessels, they always taper down and gradually stop. Whereas the right angle vessels, they usually don't taper down. They have just a blunt ending. You also see certain crystals present on the surface of the retina. So these are superficial crystals. And that is thought to be because Muller cell is the one which is degenerated. you can get these depositions because of degeneration of the internal limiting membrane. You also see blunt right angle venues, and sometimes we have these localized thinning, and these are classically seen on the angiogram. So it's a very good way to see whether these patients have parafoveal right angle vessels. And the significance of these are the sites where you had RPE proliferation. So what does RPE proliferation mean? You get pigment proliferation on the outer layers of the retina extending superiorly. They come into the superficial retina along the right angle vessels. So you can see different types. You can just see this mild RPE proliferation. And in some cases, you have this extensive pigment here. And the FA will clearly show this staining, and you can also see these blocked fluorescence because of the pigment. This is stage 4 mactel. And finally, you have stage 5, which is subretinal neovascularization with or without hemorrhage. So in the picture on the left, you have this hemorrhage. And if you look very carefully, you can also see the OCT, which clearly demarcates the presence of a hyperreflective lesion on the outer retina. You don't see cystoid macular edema that commonly in patients who have SRNV. Whereas on the left, you have a patient who's got a SRNV without hemorrhage. Again, you can see the elevation. So just to reiterate the point that how do you judge? The main thing for a patient with mactel is, as a general ophthalmologist or a doctor who's practicing medical retina, is to see whether these patients develop retinal neovascularization, because these are the cases which require treatment. The previous all cases, whether it's stage 1 to 4, non-proliferative, they generally don't require any treatment. Unfortunately, no antivegf works. So what are the ways we can judge whether these patients have subretinal neovascularization? So the points to remember is, if a patient with mactels comes to you with a sudden drop in vision or sudden increase in the distortion of the vision, and then you examine these patients, you see either hemorrhage or exudation. So again, please note, in the early stages of telangiectasia, there is lack of any lipid exudation. So if you see lipid exudation with hemorrhage present, this could be a clear indicator of a subretinal neovascular membrane. The second thing is on the OCT. So I'll describe that OCT finding in the subsequent slides. So these are two things you would want to look out for when you're seeing these patients with macula. So if you look at the fundus image here, classically you can see this slight graying discoloration. You can see some telangiectatic vessels on the temporal sides, both in the right and the left eye. And an important tip which I follow is to examine these patients with a red-free image, because if you want to look at vascular pathology, the best way to examine them is to do a red-free filter. You basically put a green light and you can pick up even small microorganisms or telangiectasia. You don't see microorganisms in mactel, but if you want to see diabetic patients, you can pick up single microorganisms or even mactel very, very clearly when you see these red-free images. So how is the OCT in mactel? So the reason I'm showing you this retinal map is because if you look at the retinal map, I use a Heidelberg system. So each of you all would be having a different machine. So I wanted to look at your retinal maps and see how the retinal map looks like. So in a normal scan on a Heidelberg, you have this green appearance in the center, followed by this yellow-orange appearance, and finally a green appearance on the side again. So this is very characteristic of a normal scan. Why do you want to remember this? Because in patients with early stage of macular telangiectasia, you get a different appearance. You get this bluish appearance here, and usually it might be a little eccentric. So the first sign which you see on the OCT, when you do OCT on these patients, is here you may not see much on the colored image, but when you do this OCT, you get this temporal enlargement of the foveal contour and also a temporal thinning. So you can see some thinning, and also the central macular thickness is reduced. So that's another feature we need to remember. So mactel eyes usually have reduced central macular thickness. They can have distorted foveal contour. Usually it is dragged more to the temporal side, and the temporal retina is more thinner as compared to the nasal side. So these are your initial stages. You may not see any cysts here, but this is a classic sign. And if you look at this patient was seen in 2018, and we followed up this patient over a period of time. And you can see the same patient seen in August 2021. And now you see all the signs which are classically seen in patients with mactel. So you have this retinal cyst here. You also see, importantly, the disruption of the EZ, which is again a classic thing which you see in patients with macular telangiectasia. So this cyst, please note, these are not leakage cysts. So when you do an angiogram on these patients, there's no corresponding leakage in this area. Second, when you see this cyst, there's no associated thickening, because if you have leakage, the retina generally becomes thicker. Here it's opposite. Because this is atrophy of the Muller cells and the associated retinal tissue, you have cysts here. This has classically been described as an IL drape sign, Some people call it cyst, pseudocyst, or even cystoid changes. Please note, do not give injections of any form in this condition because it doesn't work. There's no way that these cysts are going to resolve with any anti-VEGF injection. So it's important for us to diagnose MACTEL because intravitreal injections have no role, and you're simply giving a risk to these patients with different conditions. So this patient is, again, if you look further, they have progressive outer retinal atrophy. So eventually what happens is you get this IL drape sign, you also get atrophy of the outer retinal layers. And classically, we see this bluish appearance in the center. So this is where these are simple clues which you can see when you see patients with MACTEL. Lastly, eventually what happens is you get RP migration. And this RP migration is seen as hyperreflective lesions in the superficial and the inner retina. And in the clinical picture, you can see this image here. This is how the plaque looks like temporal to the retina. And as I mentioned, usually it's at the site where you have the dipping vessel or the right angle vessel. It's important to see these dipping vessels because that's also the site where you can get these subretinal neovascular membranes which originate. In the last stages, you get this subretinal neovascularization where you get fluid leakage. These are the cysts. We have some subretinal fluid. You can classically describe this as probably a hyperreflective echo, or some people probably might describe it as a double layer sign. But if you look at the angiogram, you can see this intense leakage noted on the temporal quadrant. This is unlike when you see staining in patients with MACTEL. If you look at the angiogram, the OCT angiogram, the images are not very clear, but if you look at the B-scan OCTs of these images, you can clearly demonstrate the presence of these tiny yellow dots within the area of hyperreflectivity, indicating that this patient had a subretinal neovascularization. So having finished with OCT, let's look at OCTA. Now we know OCTA has been the tool which all of us have been looking forward. The important thing is it's a non-dye based angiography image, pretty simple to perform. You can perform at multiple stages and multiple times when the patient comes for follow-up. So according to the OCTA classification of MACTEL-2, you have non-proliferative and the proliferative type. Non-proliferative, you get telangiectasia in the deep intraretinal capillary plexus and in the intermediate. So in Heidelberg, you also have 3 capillary plexuses which are seen: superficial, intermediate, and deep. So usually we know that this MACTEL is a disease of the intermediate and the deep capillary plexus. And then in the stage 2, you have capillary telangiectasia involving the superficial capillary plexus. And the stage 3 is when you have full thickness vascular invasion, where even the avascular retina gets involved. These are non-proliferative changes. Please note there's no treatment for this. In proliferative stage, these are complicated by subretinal neovascularization and also associated with subretinal fibrosis. So these are some of my cases. This patient had stage 3 non-proliferative on OCTA. So if you look classic signs, you have this cyst present, you have the loss of the retinal tissue here, disruption of the external, the ellipsoid zone. These are the classic angiograms. You see the dipping vessel, you see the staining here, and the central clearing. The OCTA clearly demonstrates that you have abnormality in both the deep and the superficial layer. So this is stage 3. This is stage 1. We have predominant involvement in the deep capillary plexus and the intermediate ones, but the superficial capillary plexus is pretty normal. Another interesting thing we see in OCTA and MACTEL, MACTEL-2 is only one of the conditions where you get reduction in the size of the foveal avascular zone. So if you have a patient in whom you see the foveal avascular zone seems much thinner or smaller in OCTA, that could also be a clue that these patients might be probably having MACTEL. Last is a patient who develops subretinal neovascularization. So these are the early phase. You see this intense staining. When you look at the OCTA image, you get these vessels which are present in the avascular retina. So what about fundus autofluorescence? Autofluorescence, classically, you see the increased hyperreflectivity in the perifoveal area. And here you can clearly see the presence of these abnormal vessels. You can also see the presence of pigment here and RP changes in the juxtafoveal area. So FAF is also very classic. These are the multimodal images of MACTEL-2 patients. A patient with color image. This is confocal blue reflectance. It's one of the first tests which can pick up whether this patient has MACTEL, even in the absence of the telangiectatic vessels. Then you have the autofluorescence images, the FFA images, the OCT and the OCTA. Unfortunately, ICGA does not have a role because the choroid and the chorocapillaris are normal in patients with MACTEL type 2. So a brief about the treatment for non-proliferative patients who just have cyst with thinning of the retina, please do not do any injections because there's no role of antivegf injections. And proliferative stage when they have subretinal neovascularization. So I forgot to mention about the OCT. So we mentioned about the signs and symptoms when the patients have subretinal neovascularization. Sudden drop in vision, metamorphopsia, presence of blood or lipid exudation. And unlike in MACTEL patients where you are thinning of the retina, if the patient presents with thickening, that could be an indication that there's a subretinal neovascularization. So this is an important thing you need to understand. Macular telangiectasia in non-proliferative stage is the retina is thinner, but if you have in the perifoveal area an abnormal thickening, this would probably indicate that the patient is developing a subretinal neovascularization. With this, I would like to conclude my talk. Thank you very much for your kind attention, and I'm open to questions.
Thank you very much, Dr. Prasan, for this excellent presentation. As usual, it was very, very nicely prepared and very clear and to the point. Actually, I learned from that a lot. I think all my colleagues, they are hearing you, they get to know now how to look for the MACTEL in clinical, in the history, in the symptoms, in the OCT, OCTA, fluorescein, and what they have to do. Very nice. Thanks a lot. I will leave if there is any question first from any panelist here or any add, Dr. Tariq or Dr. Danish or Dr. Safi. Please, Dr. Tariq.
Yeah, Prasan, thank you for the presentation. Very nice. I just ask you, I mean, subretinal neovascular membrane in these cases, is it which type of, is it type 1, type 2, or type 3? And the second question, I mean, we know that we get this type of subretinal membrane at late stage, stage 5, where the neurodegenerative process has happened. Is it worth it to treat this patient? I presume at that stage, stage 5, when they get this new membrane, they will have a low vision already. Do you think treating this membrane is going to help to regain some vision?
So, Dr. Tariq, actually, before the advent of the OCT and the OCTA, not much was known about these membranes. So the thought was that these could be choroidal neovascular membranes. But later on, over a period of time, it was realized that the source of these subretinal neovascularization actually starts in the deep capillary plexus, because that's the site from where the neovascularization starts, and then extends posteriorly, and then enters the subretinal space. So to some extent, you could call this as a RAP lesion or type 3, similar pathology. But
so type 3, yeah.
The problem is that these patients don't have drusen, they are of the younger age group, and they never develop a pigment epithelial detachment. So yes, you would say that the pathogenesis is similar to a RAP, but because there's already pre-existing telangiectasia, that predisposes the eye to develop the subretinal neovascularization. The second point is the subretinal neovascularization usually occurs at the site of the right angle dipping vessel. So when you see these right angle vessels, the importance of that is you get pigment deposited there. And sometimes if there is pigment and you have a subretinal neovascularization, you may not be able to pick up because the pigment acts like a block fluorescence on the angiogram. So that's one of the reasons why OCTA plays a very, very important role. Because if you have block fluorescence from the pigment, you don't know whether you're not able to see these vessels, you don't know what's leaking. And sometimes you have the staining as well. So you don't know whether it's a stain or it's leakage from the neovascularization. So there are clues which you want to pick up. So OCT is one clue. You have increased thickening. OCT is another thing. So OCT is a very reliable, diagnostic modality to diagnose subretinal neovascularization. I show you some of my cases of subretinal neovascularization who were treated with injections, and they really did very well. So in the subsequent talk, I'll have some cases that I can share you. So quite a lot of patients do well with injections.
Some the CNVM with the macular telangiectasia is usually a type 2 CNVM. Only occasionally you can get a RAP lesion associated with this. So you have both the things possible, but more often it's a type 2 lesion. And type 2 lesions behave very well with antivegf agents, which explains why you got such great results with the treatment also. So the other ones...
Same thing is with RAP. RAP lesions do very well with antivegf.
So in fact, one of your patients, one of the OCTs you showed, I thought had a small RP detachment with the CNVM. So it was probably a early RAP lesion.
I think that patient had hyperreflectivity along the RPE. So you get these multiple humps
It
there.
was going, yeah.
But I don't think there was a PED.
It was one patient I thought had a PED. So anyway, so I'm just telling you that
PED is
so if you
generally
see a
very
small
rare in
PED
macular.
yeah, but if you see a small PED with telangiectasia and a suspected CNVM, that's a RAP lesion most often. So
yeah, but the thing is that the problem is it's never a disease of the RPE.
yes.
So because the RPE in these patients are quite robust, it's very unlikely that the neovascularization can penetrate the RPE.
Yeah, I told you, most likely to be a type 2 CNVM. Most of the cases I've seen of CNVM and these are type 2. And on a fluorescein angiography, you can see the leakage and you see a smaller area of dense leakage. So that also gives you a clue that you're dealing with a CNVM within a juxtafoveal telangiectasia. And one more point I'd like to make is for those who do a fluorescein angiography in juxtafoveal telangiectasia, you could get confused because it actually looks like a late leakage from an unknown source. Actually, it's classically the picture described for an occult CNV of the occult CNV for occult leakage, late leakage from an unknown source. But the difference will be when you see the OCT, it's almost characteristic. There's no way you can make a mistake of a CNVM once you do the OCT. So, and of course, if the clinical picture with juxtafoveal telangiectasia is much more characteristic, different from that of a CNVM.
That means Dr. Danish and Dr. Prasan, we need to do OCTA also and fluorescein, and both of them, then we can have a very good clue about MACTEL2.
I generally don't do FA in patients who are non-proliferative. I might do a OCTA if I suspect anything, but I generally don't do an FA because it's straightforward. We're just wasting. It's not going to give you any additional information. It's just to confirm the diagnosis.
On OCTA more than OCTA more.
Yeah, I rely on OCTA. The OCTA is able to pick up the membrane because that's the only thing you want to see. Because these patients, if you remember, I showed you the OCTA of one of the patients who was seen in 2018 till 2021. You have this gradual thinning in the retina. Unfortunately, they tend to lose vision, and there's not much we can do. So the aim here is to try and diagnose subretinal neovascularization at the earliest, so that you can treat them before irreversible damage happens. Because I'll show you a patient with early CNVM and a late CNVM, not CNVM, SRNVM, and they had a massive bleed. And
is there any role of PDT, sir? Is there any role of PDT for non-proliferative types?
No, they have tried PDT, they have tried TTT, they have tried laser. Nothing works. So at present, there is a research being done by Emily Chu and a group in NEI. They are looking at ciliary neurotrophic factor, which is supposed to be secreted by the molar cell. And they looked at two things when they did this injection. They looked at the size of the ellipsoidal zone and the reading ability. And they found reading ability in these patients is much lesser because they have this lack of photoreceptor cells in the center. So what they found was when they give them the CNTF injections, actually the reading speed becomes better. And in some cases, in the early stages, there can be reversal of the loss of the ellipsoid zone. I'm not so sure about the exact data, but this is something which I read, I remember about 2 or 3 years back. So that's only the research being done for non-proliferative stage.
I think it's important to keep in perspective that juxtafoveal telangiectasia is a relatively benign disease. It's very, very slowly progressive, if at all. It can take years to progress. And vision loss to the point of blindness is very rare, except when CNVM occurs. Though you can have moderate vision loss in some of these patients. In some of these patients, not most of these patients. Most of the patients have good vision.
I think they tend to lose vision because of foveal atrophy. So usually they'll have loss of this.
So it's a long-term. It's not early. It takes a long number of years before that happens. What I'm saying is, otherwise you make a diagnosis and scare the people that you're going to get foveal atrophy and you're gone. No, you're not going to get foveal atrophy. It takes years for foveal atrophy to come.
Yeah.
I think maybe we can discuss any further points after we, when Dr. Prasan and Dr. Tariq show the cases. So now we can go to Dr. Danish Talwar and to his talk. Please, Dr. Danish.
And thank you, Dr. Amri, for inviting me here. It's always a pleasure to be in these meetings, which are very interactive and really good for keeping your mind active, So let's go ahead to the topic for today, peripheral retinal vascular disorders. I'm told that the basic retinal disorders like diabetes and hypertensive retinopathy and all have been covered already. So we are now dealing with the disorders which actually, this is a set of disorders which is predominantly, which involves the mid-periphery and peripheral retina, though it may come into the central retina also. And these have various etiologies. The important thing is that, well, I've tried to classify them. You can have inflammatory disorders, where the predominant feature is retinal vasculitis. And this could be isolated inflammatory retinal vasculitis, or you could have the same in association with systemic inflammatory disorders, or it could be a complication of infective or neoplastic disorders. So this is one group of retinal vascular disorders. The second is secondary to hematological disorders. And the third is peripheral vasculopathies like Coats disease or familial exudative vitreoretinopathy. And I'll just touch upon peripheral exudative hemorrhagic chorioretinopathy, which is more of a choroidal rather than a retinal disorder. Now, peripheral retinal vasculitis is basically areas of active vascular sheathing, which look like whitish area. I'll just show you the pictures, followed by retinal edema and cystoid macular edema. Because of the vasculitis, you could get an occlusive vasculitis also with cotton wool spots, development of a BRVO or CRVO, or sometimes even a BRAO or a central retinal artery occlusion. Once you have an occlusive vasculitis, you could develop capillary non-perfusion, which, if it's extensive enough, can result in neovascularization. And this is peripheral neovascularization. This is how in diabetics, you have the neovascularization at the disc and within just at the edges of the arcade. But this is at the edges of the capillary, at the posterior edge of the capillary non-perfusion. Now, it's also important to keep in mind that sometimes you can have occlusion by microthrombosis of retinal arterioles or branch retinal arterioles. Now, the important thing is they don't have too much of intraocular inflammation. Sometimes there may be very little intraocular inflammation along with this. How do you diagnose it? When you look at it, actually the diagnosis stares at you in your face, and I'll show you the photographs. You want to confirm it. Fluorescein angiography is a great tool for confirming active disease. In the active disease, you have leakage, you have which can be focal or it can be diffuse. You can have, and the important thing is, clinically, it may not look like there's so much leakage, but when you do a fluorescein angiography, you can find very extensive leakage in these patients. Fluorescein angiography can also help you to delineate the capillary non-perfusion and neovascularization. And sometimes these patients can have a disc leak due to either primary infiltration, like in sarcoidosis, or as a secondary vascular inflammatory change. Now, just to show you some photographs, you can see over here, this whole branch, this whole retinal area is retinal vessel has sheathing. This is active. This is an occlusive vasculitis, so hemorrhages have formed around it. You can see a similar thing here. Extensive sheathing is happening, various parts. It's not continuous. There's a clear area, a focal sheathing here, and along with the sheathing, you have these hemorrhages, which are a sign of the vasculitis, which are a sign of occlusion, micro-occlusion at some times. You can see a similar picture in where there is only mild focal sheathing, like you see over here. And if you don't look for it carefully, you can miss this. Along with this, in this case, we also have some retinal infiltration. Now, this is another such patient. Now, basically, in in our country, these are often labeled as Eels disease. There are actually, if you have an isolated retinal vasculitis, no other systemic factor, you call it Eels disease. In our country, there are endemic areas where you could have a higher propensity of this kind of isolated vasculitis. But when we do their tuberculin sensitivity test and investigate them for tuberculosis, some of them seem to have tuberculosis also. So, or have had a history of tuberculosis. So maybe this, in those patients, it's a hypersensitivity to the tubercular protein. It may not be an active infection. Again, this is another patient. You can see focal retinal vasculitis in this, and this is beyond the arcade. This patient, which I showed you, also had very severe macular edema with a neurosensory detachment, which resolved over time and became completely normal. So this is the good thing. These patients can be treated well. Now, just to show you another patient, and this was a patient whose active vasculitis has been taken care of. And now you can see there's a huge amount of on fluorescein angiography, huge amount of peripheral non-perfusion. You can see a neovascularization, these abnormal vessels forming over here. And actually, these are vascular anastomosis. You can see carefully look over here. You see these vascular anastomosis and also these kind of hairpin anastomosis. I'm showing you these because these are also seen in some hemoglobinopathies. Now, the important thing is you can see that while, in addition to that, while clinically this patient was looking all right, but there's still some leakage occurring from these vessels. So despite the fact that clinically the patient was looking all right, on fluorescein angiography, you find some degree of subclinical activity is going on, and there is some furring over here of these small vessels. Now, we actually decided to do laser for this areas of capillary non-perfusion, and this patient settled down. But you can still see over here, there are areas over here where there's capillary non-perfusion. This was a healed patch of vasculitis. So this is what you can see in these patients with vasculitis. Now, to show you another patient, and this is the other eye of the same patient, to show you the whole course of events, how it moved from a normal eye over here to development of active vasculitis. You see over here, look carefully here. Now, you know this is active vasculitis because from here, the early stage to the late stage, it becomes furry. Again, you see over here, I don't know if you can see my arrows, but you see over here, this vessel has become furry. This is sheeting around, focal sheeting because of this vasculitis. It's developed some hemorrhages, developed capillary non-perfusion. And you can see again this little furring over here in the nasal area. So much more changes than you would be seeing clinically. Over time, despite the fact that we had done some laser to the CNP areas, the patient has developed this neovascularization. And where does this develop? At the edge of the area where there was capillary non-perfusion. And you can see some capillary non-perfusion left here, some left in the superior area. And that's the stimulus for this neovascularization to form. And despite further laser, because there's a lot of capillary non-perfusion here, this is still progressing. So we laser this patient again now. Now, what this kind of picture of isolated vasculitis may be less, it may be more, can be because of infectious disorders like toxoplasmosis, rickettsial disorders. It could be bacterial. I talked about tuberculosis. Syphilis is a great mimicker. It can do anything. Lyme's disease. Cat scratch disease usually doesn't cause that, may cause a little bit of vasculitis in addition to the neuroretinitis. And sometimes it can happen with viral disorders also. Now, how would you, when you see a patient of peripheral retinal vasculitis, how do you go about diagnosing it? Well, look at it whether it's the veins or the arteries. Phlebitis is more common in Behçet's disease, tuberculosis, sarcoidosis, and Eels disease. Arteritis is more common with associated acute retinal necrosis or IRWAN, and sometimes in SLE and PAP. There are patients who may just present with entire periphery with small cotton wool spots, and that can happen as part of HIV retinopathy or SLE polyarthritis nodosa or Wegener's granulomatosis. And if you see isolated retinal, intraretinal infiltrates, that is often a feature in Behçet's disease. Another important syndrome of retinal vasculitis is what looks like a frosted branch angiitis. This happens in 3 different conditions. It can happen because of lymphoma or leukemias due to infiltration of malignant cells. It can happen because of viral infections or autoimmune disease, as I've mentioned. Yeah? Or it can be an acute idiopathic angiitis. The other conditions could be IRWAN, which is fairly rare, and necrotizing retinitis with vasculitis. Now, just to show you, this is not a very severe case of frosted branch angiitis, but you can see a lot of vessels inflamed. But this is more classical, where you can see these vessels are all inflamed. Lots of inflammation starting from the disc, going into the periphery. When you see this kind of picture, you need to investigate and rule out any of the systemic vasculitides. And if that's not there, consider it as an acute form of the disease, an idiopathic form of the disease. The good thing is it responds well to steroid therapy. Just to show you a patient of Behçet's disease, where you can see these localized intraretinal infiltrates, and this patient was a proven case of Behçet's. Now, in this case, you can see when you look at the picture, there's much more leakage on fluorescein angiography, and sometimes you'll see this kind of furry leakage, which is quite diffuse. You see this, it is very, very extensive in the periphery. So you know, sometimes the fluorescein shows much more severe changes than what you see on a clinical picture. Now, when you have a patient of retinal vasculitis, first of all, you look for any associated systemic disease, rule that out. And if there is no such thing, you need to do a complete workup with a CBC, VDRL, blood chemistry, urine analysis, tuberculins. Just give me a minute, please. I'm sorry, that's my dog interfering with the urine analysis. Sorry. Tuberculin,
also medical retina.
HIV serology, and a chest radiograph. The important thing is the mainstay of treatment is usually systemic steroids, but specific immunosuppressive treatment could be very useful in these conditions. The next group of conditions is hemoglobinopathies, of which I will just give you a brief introduction to sickle cell retinopathy, but I don't have pictures of the basic features because we don't see it in our country. Basically, this is because of sickle cell disease or a form of disease that are called hemoglobin SC disease. Proliferative retinopathy is most common in the SC form of the disease, less in S thalassemia, and least in sickle cell disease. But sickle cell disease is more common than SC disease. Now, the important thing is that this is an occlusive retinopathy. Again, it's an occlusive vasculitis. Actually, the clinical pictures are not very different from what you see in eels in the peripheral. In the periphery, I will just show you that. Now, sickle cell retinopathy is of 2 types: non-proliferative, where vasoocclusion occurs, local ischemia occurs, and that causes retinal hemorrhages from the superficial blood vessels, which are called salmon patches. Initially, they are red. They are not salmon colored. They become salmon over time because of hemolysis. Then you have the sunburst sign, which is basically because of proliferation and migration of RPE in response to the hemorrhage. And in the late stage, you can even develop angioid streaks in these patients. In the proliferative disease, you have peripheral arterial occlusion. Then you have peripheral arteriovenous anastomosis, which is dilated pre-retinal capillaries. Finally, neovascularization, which is CFAN and at the posterior border of non-perfusion. And then, of course, vitreous hemorrhage and traction detachment. Now, actually, what I showed you in Eales disease, if you look carefully, the same kind of thing is happening here. You see the capillary non-perfusion, you see the vascular anastomosis, you see these are the pre-existing capillaries which have opened up, they're not leaking. This is not neovascularization. And then finally, when you got these neovascularizations, because they are small, they don't look that much like a CFAN. When they become very big, they become more like CFAN. And in Eales 2, you can get CFAN neovascularization. And these occur at the posterior edge of the capillary non-perfusion. So this is just to show you that to let you have a mental picture, but this is an Eales disease patient and not a sickle cell patient. The other important condition where you can get changes is in anemic retinopathy. So anemia occurs when the hemoglobin goes down below 6 grams per deciliter. It can cause hypoxia, causing either soft exudates. It can also cause microtrauma to the vessels and retinal hemorrhages and retinal edema. What you see over here is a rot spot. You can see multiple rot spots in this patient because of the anemic retinopathy. These slides of anemic retinopathy and Bessett's have been given to me by one of my colleagues, Dr. Manisha Agarwal, who works in Shroff Eye Center. Now, another group of disorders, which I said, the vasculopathies, and this is an important one, Coats disease. Unlike macular telangiectasia type 1, this is beyond the, this is beyond the arcade. These are in the periphery, all over. In this eye, of course, you can see over here, I've lasered this. You can see these vascular anomalies, dilatation, saccular dilatations over here. This is the earliest stage of Coats disease. When this progresses, it causes exudation, and finally, it can cause exudative detachment, like you see over here, and with these vascular anomalies in the periphery. Now, basically, Coats disease, the stage 1 is only retinal telangiectasia. In stage 2, there is telangiectasia with exudation, which could be extrafoveal or foveal. Stage 3 is an exudative detachment. And stage 4 is a total RD with glaucoma. Now, you see, this patient had lots of peripheral changes. This is the left eye of the same patient I showed. This was the right eye, this is the left eye. And you can see these small changes over here, the vascular changes. All these have been lasered, but he had extensive macular edema initially with hard exudates. But this is now almost 3 years later, and this edema has all subsided. The laser worked for this patient, and the patient still maintains 6/12 vision. Incidentally, he came to me with counting finger 3-meter vision, but after the laser, after the exudation disappeared, the vision improved significantly. The other important disease which we need to be aware about is familial exudative vitreoretinopathy, which is a hereditary disorder and can cause progressive visual loss. And it's progressive and more severe in young children, stabilizes after the age of 20. So in young children, the very young children, you may find this disease as traction detachment. In older individuals, this patient is 50 years old, and incidentally only I found an RD in the other eye, and I thought that this was not looking quite normal. And when we did the angiography, we found this peripheral neovascularization and extensive capillary non-perfusion beyond that. These patients can develop traction detachment also. So, and the last condition that I'm showing you is, I don't have the clinical picture. It's difficult to take this much into the periphery, but you can see these are polyps. There is exudation in these areas, the hemorrhages, and on when you do an ICG, you can actually pick up the polyps, you can pick up and you can see these exudative and hemorrhagic changes. This is a peripheral exudative hemorrhagic chorioretinopathy. This patient also had as added occult CNV, which is not a common thing, but this patient had it and he responded well to treatment. So this is another condition you need to be aware of, especially when you have a patient who presents with large subretinal hemorrhages in the periphery. So because these are often confused with melanoma and end up being mistreated. I just wanted to mention that point, though this is not really a retinal vascular disorder. Now, as you can see, there's a vast array of peripheral retinal vascular disorders. They have varying causes. We need to have a clinical acumen to do the differential diagnosis. We need a high index of suspicion. We need to do targeted investigations. And with this, we can do successful management for many of these patients because these are all treatable conditions. The infectious ones require added specific anti-infectious treatment. And for the inflammation, you need to manage with steroids or immunosuppressives, and you can get very good results in your patients. Thank you very much, ladies and gentlemen. This is an overview. It's not really in-depth, knowledge about the subject, but I thought it's better to give a wide view of a wide overview of the whole subject. Thank you very much.
Thank you very much, Dr. Danish, for this an excellent presentation as usual. I know there is a lot of diseases you have come across over. Maybe we need for each one separate webinar to discuss in detail. Maybe for today, it's great that we just come across all the different differential diagnoses with some highlights of point about each disease. I think maybe in future we can make another more than 1 or 2 sessions only to discuss the details, especially the most common types of the peripheral vascular disorders. If there is any comment or questions to Dr. Danish from the panelists, then we can go to the question available from the panelists, from the attendees. Then we have to move very fast because we are already crossing the time. I don't anticipate that we will go that much, but I think the discussion was of great in the first, and I think in the presentation of Dr. Danish is also worth to discuss. Okay. Dr. Tariq, please, if you have any comment or questions.
Yes, Dr. Danish, thank you for the presentation. Just the last disease you spoke about, it is the peripheral polyps, choroidal polyps. I never knew that it was polyps. I thought it's just eccentric disciform because when I was in UK, I used to see them. They're more common in elderly patients over 75 and 80 years old. And most of the time, as you mentioned, they present with the dense subretinal hemorrhage, which can mimic melanoma. The other presentation is really dense vitreous hemorrhage as well. They can present with that, and most of the time they end up with a really big scar, a disciform scar, since they have been named eccentric disciform scar or extramacular. Yeah, but I never knew that it was polyps originally.
Yes. So the important thing is that it can be managed. You can control the disease with aflibercept, and I actually then go after I've given an anti-VEGF, not Lucentis, usually aflibercept. Then I will normally delimit the entire area and then do focal treatment by laser. You see, these are easily amenable to laser, and otherwise they will present to you with a huge bleed and you can lose the eye. So this is quite important.
Prasan?
That's an excellent presentation covering all the aspects of peripheral vascular disorder in a very short time. Amazing, Dr. Dinesh. Thank you very much.
Dr. Safia, any question or comment? Okay, Doctor. Okay, so okay, there is one question. Also, ROP, very important and common cause of peripheral vascular distributions. Dr. Danish, if you want to comment about this
Regarding
comment. ROP, he's saying in RB, also in ROP, very important and common cause of peripheral vascular distribution.
Yeah, frankly, yeah, I was not going into the pediatric age group, so that's why I admitted it, I left it. Even FEVR, I only touched because it's there in adults also, in the older age group. FEVR can present is confused with ROP in very small children. ROP also has a similar thing. If you don't manage it, you will end up with peripheral neovascularization, and then you will in stage 3, and then you will finally end up with attraction detachment. So again, that needs to be managed too. There the management depends on anti-VEGF agents and laser, as compared to these others, other kind of retinal vasculitis. So that's two different situations. And FEVR, of course, requires laser and maybe even peripheral buckling if there's traction. So these are diseases which need to be kept in mind. At the moment, we were not discussing ROP, so we were not discussing pediatric disorders, so I did not discuss about it. Yes, but it can cause all this.
Thank you very much. So we can go now very fast because we are crossing the time, if you don't mind. To the last, Dr. Siddiqui and Dr. Prasan, if they can share with us the cases telangiectasia in a very fast, please.
Dr. Prasan, you want to go first?
Yeah, already he shared his screen.
Okay.
Okay, go ahead, Dr. Prasan. Can you just unmute yourself and go fast, please, on the cases?
Yeah. Can you see my slides?
No, you already, before you are showing. Yeah.
Okay.
Yes, now, please.
Can you see my slides? Am I audible?
Yes, yes, please. Yeah.
Okay. So I'll quickly go over these cases. So this is the first case is a 62-year-old lady with vein occlusion with long-standing macular edema in the right eye. She's had multiple antivegf injection and vsozodex in the past, and the vision is counting finger 0.5 meter. Right eye actually had nuclear cataract with action macular detachment, macular edema, and she had Mactel type 2 with a central macular pigment. So these are her multicolor images on the Heidelberg. You can see the extensive hemorrhagic vein occlusion. There's some central pigment here, and that's the image of the left eye. Again, classically showing the presence of a pigment and a dipping vessel here. This is the OCT of the right eye. Note, because she's got sort of a atrophy in the central area, you won't see an edema happening here. Because if you classically see macular edema in vein occlusion, you'll have a large central cyst and then multiple surround cysts on the side. And because she's got this atrophic change, there's hardly any swelling in that macular area. She's got this epidermal membrane, large cysts on either side. This is the left eye, which has again classic features of Mactel. You have this cyst here, you have loss of EZ, and you have this pigment here, hyperreflectivity on the OCT. So this is classic of Mactel in the left eye. So she presented a few months later with reduction of vision in the right eye and with vitreous hemorrhage. So you can see this extensive vitreous hemorrhage, at which point of time we decided to operate her. So 2 months post phaco-IOL, PPV membrane peel, and an vsozodex injection and laser. This is how her macula looks like. So her vision improved from counting finger about 0.5 meter to 660. Not a major improvement in vision, but you can see the near normalization of the macula. And you can also appreciate the pigmentary migration here, and no macular edema in this patient. This is at last follow-up in the month of January this year. You can see the pigmentary change, you can see the sclerosed vessels, and that's the left eye. Last follow-up, she's got a similar image as in Jan 2022. So this is case 2, a 58-year-old lady who was referred for management of a macular hole in the right eye. And incidentally, when I examined her, she had actually Mactel type 2 in the other eye. So this is a patient who developed a macular hole, which can happen in patients with Mactel. That's one of the complications. So this is the autofluorescence image, this is the infrared, and that's the OCT. You see these cystic changes here. It looks a little not classic of a macular hole. The edges are not very clear. In fact, you can also see some cysts which are partially open. The important thing to understand in these patients is, despite a good closure of the macular hole, they may not achieve significant improvement in vision because of coexisting diseases. So that's the left eye. You can see this small classic interretinal cyst on the temporal side. You can also see the temporal enlargement noted here. The autofluorescence also shows the absence of the sort of hyperfluorescence noted on the temporal quadrant here. She underwent PPV ILMP SF6 gas injection. You can still see the presence of the gas, and the macular hole is completely closed. And you can note that, yes, the hole closed, but because of the loss of the outer retinal layers, her vision did not improve significantly. So this was in 2017, and when she last followed up in 2020, you can notice that though the hole closed, there is this loss of ellipsoid zone happening here, which is indicative of progression of MACTEL in these patients. Third case is again a patient, an interesting patient actually. So she's a 54-year-old Indian lady with a breast lump removal, and she was using tamoxifen, and this is her vision is 0.5 in both the eyes. Anti-segment is normal. The retina is attached. The OCT, if you look at the OCT, she had these defects in the outer retinal layer with disruption of the interdigitation zone and the ellipsoid zone. We diagnosed this case as MACTEL type 2, but we also kept tamoxifen toxicity as one of the possible differential diagnoses because she was in tamoxifen. And this is just for us to remember what is the difference between MACTEL and tamoxifen. So we see crystals in MACTEL, but they are larger in tamoxifen. The location of the crystals is perifoveal in MACTEL, when in tamoxifen they are perifoveal and can be found right up to the ora. The crystals in MACTEL are located in the inner layers because they are associated with degeneration of the ILM, which are the footplates of the Muller cells. And these start in the nerve fiber layer in the inner plexiform layer, but in late stages, all the layers will get involved. The main cause of MACTEL is loss of photoreceptor layer. Here you have cyst formation and axonal degeneration of the nerve fiber layer. EOG is reduced here, whereas is normal in MACTEL, whereas reduced in tamoxifen. And recovery of vision is not possible in MACTEL, but with early stoppage of the tamoxifen, you can have some visual recovery. And the recommended dose for tamoxifen is 10 to 20 milligrams. So this patient was followed up in May 2017 and November 2017, and with ampular grid. And this is how she looks like. She has this atrophy in the peripheral part. Note there's slight thickening here, which, as I mentioned, is not classically seen in MACTEL patients. You can see the central blue dot here, again indicative of thinning of the central macular thickness here. She reported to the clinic with reduction of vision in December 2019. You can see a sudden increase here in the nasal aspect in the right eye. The left eye was pretty much the same. And these are angiography images. So you can see this telangiectatic vessels. The dipping vessel is actually on the temporal side, but she developed a subretinal neovascularization on the upper nasal quadrant, which may occur, but a rare phenomenon because generally it occurs at the site where you have the right angle dipping wave. These are images of the left eye here. The OCT-A clearly shows the presence of a neovascularization in the right eye, not in the left eye. And Dr. Tariq asked us how we treated this patient. We treated with her with aflibercept injection. You can see the reduction in the thickening here following the first injection. This is the OCT after the first injection. You can see a reduction in the vasculature there. After the second injection, her vision actually, which has dropped to 0.2, improved to 0.6 after 2 injections. And we continued further injections, and finally you can see there's near normalization of the retinal thickening. So this is at last follow-up. You can see the absence of the edema here. You don't note the thickening in the nasal quadrant. The left eye still has this thickening, but there was no OCTA indicative that there's a membrane in this eye. The last case is a 61-year-old gentleman with sudden loss of vision. So these are classic images of the right eye showing the presence of MACTEL. By now you would have been able to pick up, you can see this IL-8 sign, you have this atrophy in the peripheral part, or you can see the staining of the perifoveal area and telangiectasia noted in the temporal quadrant. The OCTA is normal, and this is the left eye. Now you can see a massive subretinal hemorrhage here, and the FA clearly shows the presence of telangiectasia and staining of the vessels. The OCT shows the presence of subretinal hemorrhage, and the OCTA also shows the presence of a membrane. He was treated with injections. This is post 1 injection. He just came in the month of March, and we had still some images, but I don't have them, so I haven't shown it. But this is after the first injection of aflibercept. So we have patients who have combination of diseases. You have MACTEL which can be complicated with macular holes or CNVM, Sometimes they might have lamellar macular holes, and you can have other associated features like vein occlusions, and even some patients of mine have CACR. So thank you very much for your kind attention.
Thank you very much, Dr. Prasan. We can go directly to Dr. Tariq, please. If you can share your screen to share with us your case, please.
Yeah, thank you, Dr. Muhammad. My case is quite quick, really, the shortest. I mean, it's a part of our talk today about peripheral retinal lesions. As we know, this is a diabetic patient who's a 50 years old gentleman with a history of diabetes for 20 years. He has a history of hyperlipidemia, hypertension, and obesity, and his vision in both eyes is quite good, 6.9 in the right and 6.12 in the left. As you can see here, that with this is a montage of different pictures taken different directions of the eye gaze, okay, and they have montaged together. And as we can see here, that we can see NVE front in the left eye here. So with our conventional imaging, it really doesn't become a potential peripheral retinal lesions, as peripheral retinal lesions assessment is quite important in assessment of diabetic retinopathy plus uveitis and other diseases, vasculitis, as Dr. Dinesh mentioned. Peripheral retinal lesions in diabetic patients can be really predictive of the disease progress. It can affect our screening, it can affect our classification and treatment approach. So you can imagine with me, if we do the retinal screening, we do the 45-degree, we take the macula-centered 45-degree here and the optic disc center. So this lesion is going to be out of our conventional imaging for diabetic retinopathy. But using this montage, and differently, if we use the ultra wide field, which goes up to 100-degree, nearly the total area of the retina, we can see a lot of pathology. We can change our approach to the patient. So, I mean, with the conventional imaging, we can classify this patient maybe moderate to severe non-proliferative disease. But if we do the montage and go to the peripheral areas of the retina, we can say differently is PDR. So our approach is quite different in these cases, you know, and this is the take-home message here. So if you have a patient who was really approaching severe non-proliferative diabetic retinopathy, you need to go to the periphery and have a look on these predominant lesions, because they can really have a predictive value of 3 folds of progression of diabetic retinopathy and 5 folds of progression to PDR. So if you have such a lesion, then this patient is really at a high risk 5 folds to develop a severe PDR. Thank you.
Thank you very much, Dr. Tariq, for this a brief case, but very interesting also, and highlight a very important point to go for a wide field or to examine the periphery. And I think we have done one session about this one previously with Dr. Danish about looking for the periphery and how to deal and how to manage in these cases. Thank you very much. At the end, I know we are already behind the time, so we will, I think most of the questions, they are available already. Maybe we answer it in a way or indirect way. So thank you very much, Dr. Satya, for your presentation, Dr. Prasan, Dr. Danish. It was all the time our pleasure to be with us. Thank you. And I know it's a short notice for you about the presentation, but it's really an excellent. And I hope that maybe in future we can have more times to explain each of these diseases, because they are very important and we are sometimes face it and we need to know and to highlight it more. Thanks, Prasan, for the cases, and your presentation was excellent, especially the previous one, and the cases also make the, I mean, about you emphasize and you targeting also the sign and how we can find and differentiate the telangiectasia from other things, MacTel. And so thank you for all of you. Thanks for the sponsoring company. Yes, Dr. Danish, please.
Prasan has given food for thought. Actually, if you notice, both the surgical cases, after you've done your eyelid peeling, the telangiectasia has disappeared. I'm just wondering, is it worth considering this as an intervention?
Yeah, so the problem is that, yes, there could be some element of traction. So there are some studies where they've tried to peel the ILM in these patients. But the problem is the underlying cause is the degeneration of the neural cells. So over a period of time, the cyst will tend to recur.
maybe the structural effect goes off because the Mueller cells are keeping it there. And the ILM is pulling it off. Now, if the ILM goes away, it just lets it collapse on itself. So that's why.
So one of the theories behind peeling the ILM was you induce sort of a little bit of scarring of the Mueller cells, and that's one of the reasons why in DME also you can have the reduction in the macular edema. But the problem is you're causing more damage by peeling the ILM because the ILM is a part of the footplates of the Mueller cells. So if you peel them off, it's probably causing more damage. That's my thought. I don't know.
Yeah. And one more thing, I have a patient of macular telangiectasia with a macular hole who had 6/6 vision, and I decided not to operate, and the hole closed over time. So
that can happen.
That can happen.
So we treat the vision and the patient, not the OCT.
Thank you very much for all of you, and just reminding our colleagues that the link of the certificate is available on the chat for the previous and for the new one. Also, we are going to have our next meeting on Friday, inshallah, 27. So we are inviting all you to be with us, inshallah. And at the end, thank you for all, for the speakers, for the panelists, and for the sponsoring company, the management event, and all participants. They are with us until this time. Thank you very much and good night. Goodbye. See you, inshallah,
Thank
next
you,
week.
everyone. Thanks a lot.
Bye.
Thank you.
Bye. Bye. Bye.
Bye. Thank you.